time to do that. And if he has sleep apnea, you put the burden of buying a machine and sleep with a mask on the face. Who wants to do that? In fact, I ran a pilot project of trying to diagnose sleep apnea in Pakistan. My own dear family members, who I felt were strongly likely to have sleep apnea, I tested them. They were sleep apnea. I brought the machines for them. They want to use it. The compliance is an extremely big issue all over the world. So testing is difficult. Recommending treatment is difficult. Compliance is difficult. When we have basic health issues of access to water, sanitation, and your basic management of hypertension is fraught with difficulties at all levels. Talking about sleep apnea and its fancy management, I think I'm not doing a good job in trying to tell you something which may not be so relevant. So I will try to rearrange my talk, trying to address and focus on what are the priorities in your particular setup and what to learn from my talk to implement in your lives and in your careers. And even if you took one lesson from it today and implemented it in the rest of your life, I would have done my job. That at least I made a difference in one person's life. So let me now start off with a story. So as a cardiologist in private practice, I see there's several colors in my day. I see people with bread and butter cardiovascular disorders. I see patients referred to me for pre-surgery clearance. I see patients referred to me for uncontrolled hypertension. And similarly, I take call in emergency hospitals where I see patients, all the emergencies I mentioned about. Chest pain, shortness of breath, passing out, fainting, palpitation, dizziness, uncontrolled blood pressure, congestive heart failure, arrhythmia, stroke, etc. I get involved with people with renal failure, uncontrolled diabetes mellitus, sepsis, because of the testing-driven finding of abnormal troponin. Interestingly, with COVID, cardiology is in the front line in America, because every single patient in COVID literally had borderline troponin. And with the easy access of all this testing, and you have to understand, in America and other developed countries, patient walking into the emergency room, they invite an array of tests, not that they don't know clinical medicine, but they find it more cost effective to do those things right away, so they screen the patient, streamline the management, and move on further. So the testing is done, broad-based chemistry, urine, electrocardiogram, chest x-ray, and CT scan, whatever needs to be done. But troponin abnormality invites a cardiology consult. So I have been involved with COVID management at the very early first step. So the story is about a patient referred to me from an infertility clinic. It's a Philippines nurse who is in her late 30s, early 40s, a high risk for pregnancy, who was referred to me for the management of uncontrolled hypertension. So as part of her management, I did a stress echo, which showed her blood pressure was somewhat abnormal, excessive response. In stress echo, we see it's a simple tool, but it's a very comprehensive tool. I was talking to Honorable Faculty Cardiology, Dr. Sneed, Dr. Wakar, that they were mentioning they don't have interventional cardiology set up. Honestly speaking, majority impact on patients' lives is through early intervention on basic clinical problems. A stress test with an echo assistance is a very informative tool. I see how much they walk, what happened to their heart rate, what happened to their blood pressure, how much incline they can handle, how much speed they can handle, what happened to their symptoms, what happened to their EKG, do they develop any heart murmur, do they develop any echocardiographic abnormalities, if they have any post-recovery, continued high plateaued, uncontrolled blood pressure and tachycardia, if they have early abrupt tachycardic response, with an early abrupt hypertensive response, believe it or not, that gives me such an array of information. And what just putting them on the treadmill and see what they do. And based on that, I can very well have a picture about this person's cardiovascular health and move on further. So this lady, she had uncontrolled hypertension. I recommended sleep study. She had sleep apnea. I put her on CPAP management. And she went to her infertility clinic for her periodic testing and treatment. And she was surprised to hear she didn't need it anymore. She was pregnant. And the infertility clinic people asked her what she been up to. She said nothing. I went to the cardiology clinic and did such and such. So basically, Penny dropped that she had sleep apnea that was causing rhythm abnormalities in her biological clock and hormonal imbalance, which by interrupting that imbalance, by treating the sleep apnea, she regained her normal biological clock, and she ovulated, she conceived. And then she called me 2 months later, thank you. So that is so now, what is its biological clock? So I will tell you one story. In fact, 2017, makes the protein only enough, and that protein degrades in the daylight. It's a huge interest. It increased more in 1990 and then early 2010 or something like that. So this is a talk on a forum, TED Talk. I don't know if you know this forum. I recommend that it's available online. They have their own website. TED Talks. They really invite people from very different walks of life to give very exclusive information. 5-10 minute talks of excellence in their field. So, light at night has implications. In excessive light, they have found many species are getting interference in their life cycle. Turtles, which will come lay their eggs in the post, and once those eggs hatch, Any hormone that you can think about with night? Melatonin. I'm sure all heard about it. Realize how we have made and shaped our lives with exposure to light at night in form of cell phones, computers, watching movies, and exposing ourselves to light when it may not be necessarily required. I was in Neelam, Upper Neelam, 2 nights ago, and in fact, in 1990, there was a big outage in California on the west coast. And people called, several calls made emergency that we see something in the sky, some aliens they have invaded. And come to find out, it was a Milky Way because of the pollution in the environment. And I was able to see Milky Way in Upper Neelam. And I was so blessed to see what I had not seen for so many years. So light at night, and we do not know exactly how the presence of light at night in our life implicates mechanisms of sleep apnea, but we do know it's not healthy. The people who are night shift workers, they wake up disturbed. People who use energy drinks. So these are all things which are affecting sleep. In fact, this may be poignant for me to add the sleep center because it's relevant. The sleep center, as we know, you've all read in physiology, is like a seesaw. You have different things which will make us go to sleep. Walking all day, sunlight, gravity, food, muscle chemicals, stress, eating, and then as we entrain our body to wake up in the morning, do exercise, breakfast, and certain times we go work out. So when it comes right time at night, we take a shower or whatever, go to our bedroom, turn the lights off, we go to sleep. And similarly, all night long's rest is going to fill up the batteries, so to say, of that seesaw, which had tipped in the favor of sleep. Now, the seesaw is ready to wake up, and we are ready to take on the day. Imagine if we try to create imbalance in this seesaw by doing things which are going to adversely impact. For example, we go to work out and we take a large caffeine drink, energy drink. Or if it's time to go to sleep and we use caffeine at that time. Or we're exposing ourselves to light. All these things are going to impact the seesaw and its balance and going to affect the sleep center. So let me go back to what is the physiology of sleep apnea and why sleep apnea has implications for heart disease. So definition of sleep apnea is basically interruption of the we had background the name of the people, and we had the parents who used the air entry. Clearance is the muscle. Senior doctors in the nasal muscle of the face. And there get a lot of big blood supply, more than any other muscle in the body. That's the reason. What happens is that as there is negative pressure to the face, these nerves move into the muscle. To fire those muscles up. down in sleep apnea. So if I were to say sleep apnea is a disease of the pharyngeal muscle or a myomuscle-pathy disease, I wouldn't be wrong. In fact, this is how it's been looked at. And that's where number one endocrine disorder, diabetes, might be relevant. And some people think a very high incidence of sleep apnea and diabetes could be caused by pharyngeal muscle disease through neuropathy or diabetes mellitus. So, no surprise why you would find a very high incidence of sleep apnea in uncontrolled diabetes. And in fact, in my list of specialties where there is sleep apnea, endocrinology is the number one of the very high ranking specialties. That people with uncontrolled diabetes would have that nerve damage from neuropathy causing sleep apnea. So what is sleep apnea? I'm talking so much about it, I've not even described what is sleep apnea. So it's basically interruption in the airflow, and we all have interruption in the airflow, and apnea is total lack of ventilation or air movement. So for 10 seconds is a pause. That's apnea. And hypopnea is shallow breathing, 50% decline in the ventilatory output with some stimulation and some reduction in the oxygen. So apnea, hypopnea. So we combine them together and we call them apnea-hypopnea index. We all have 5 episodes an hour, normal for everyone. Having those interruptions up to 15 episodes is mild, 15 to 30 moderate, more than 30 severe. So what happens during those moments of lack of oxygen to the body? We have sympathoadrenal discharge. That is the pathophysiology of sleep. So, lack of oxygen, sympathoadrenal discharge, which is going to cause tachycardia, uncontrolled hypertension, which is going to cause those surges, a patient waking up, unwell, gasping for air, and other important signs and symptoms of sleep apnea are waking up fatigued and tired, sleepy all day, early morning headache, tiredness, erectile dysfunction, depression, anxiety disorders. So many more symptoms due to sleep deprivation. Mind being foggy. In fact, I was reading that there is a high incidence of dementia in people who have sleep disorders. That if there is 1% lack of rapid eye movement, sleep, almost 9% increase in incidence of dementia. So, we talked about melatonin, how it impacts. We talked about the seesaw of sleep, and we're talking about sleep apnea muscle collapse. So, in addition to sympathoadrenal discharge, inflammatory pathways are active. So all the cytokines which are active in inflammation, we see they're active in sleep apnea disorders. We see vasoconstriction, we see oxygen damage, we see procoagulant pathways, incidence of blood clots, incidence of myocardial infarction, incidence of uncontrolled hypertension, incidence of stroke, atrial fibrillation, congestive heart failure, are very common in sleep apnea disorders. So during the sleep apnea episodes, when we lay down, we have gravity causing the tongue to fall back, muscles relax, and lack of firing of the pharyngeal muscles aggravates the matter to the point of mechanism of sleep apnea, causing and developing. So what is Charles Dickens to do with sleep apnea? Well, we mentioned that he described in his Pickwick Papers, a novel that he wrote. He described a character, Fat Joe. And in 1955, when the term obesity hyperventilation was first described, that they found a syndrome of obesity, hyperventilation, polycythemia, and things like is happening in people who are obese and they don't sleep well and they're breathing poorly and they have polycythemia. So one of the astute physicians said, this describes the Fat Joe, the character in Charles Dickens' novel Pickwick Papers. They called it Pickwickian syndrome. And now we know that Pickwickian syndrome is only one phase of sleep apnea. We see 10 lean people who are energy drink users, who are night shift workers, who have uncontrolled diabetes, who are on pain medications, who have depression, who are on psych floors. So there are so many different phases of sleep apnea now we see. And once we realize that it's the imbalance of the seesaw, then it's easy to envision that sleep apnea could occur in so many more specialties. In surgery, I get patients who require clearance for surgical intervention because surgery is a stressful event, and people can have myocardial infarction, uncontrolled blood pressure, atrial fibrillation, and so on. And sometimes, based on the clinical assessment of the patient, astute surgeons will insist on getting a cardiac clearance to make sure patient's rhythm is regular, he does not have any clinical signs of heart failure, there is no cardiomegaly, blood pressure is not out of control, they don't have uncontrolled diabetes mellitus, they are not getting short of breath and walking from one stop to the other. It's that, in fact, believe it or not, at this moment, in fact, for all times to come, clinical medicine is the core of being a physician. And please never forget that no matter where you go, your clinical skills will come to your rescue. 80 to 90% of the diagnosis this day is still made on a sound history and physical examination. To give you an example, somebody who comes in the shortness of breath, ascites, low extremity swelling, you needed just one test to distinguish is cardiac or biliary, liver related. You put them 45-degree angle, see their neck bleeds. It was a question I had to face in my membership examination. That do one examination and examine one system. So if you see they're pale, you look for the jaundice and you start examining the abdominal system. If you're not pale and you see their volume bloated, you put them 45-degree angle, look for the neck veins. If they're engorged, you put the cardiovascular system. And heart disease sometimes can also cause cardiac cirrhosis. So we know all those things. So please, my dear friends and colleagues, remember, clinical examination is the mainstay. No matter where you go, you work in dungeon places. If you have sound clinical skills, you will never be defeated. So that is an interesting connection to Charles Dickens, basic hyperventilation and sleep apnea. And that is the Fat Joe, ever Sleepy Joe, with a graphic description of sleep apnea. So, and I had mentioned why I had gone on to do more and more testing of sleep apnea, because I found that I have put stents, I have done their heart failure management, I have done everything else, and they still come to be tired and fatigued. And then with maintaining a high index of suspicion, and that's crucially important. Eyes don't see what mind doesn't know. Maintain a high index of suspicion, and you do that when you have your mind enlightened with all the possibilities of disease. If you maintain suspicion, and then you will test for it. So I continue to test for this. And what I did was a pilot project in my own mind that I will test every patient with cardiac emergency in the hospital when I follow them up in my sleep apnea clinic. Patients coming in with all those cardiac emergencies I mentioned earlier, myocardial infarction, chest pain, uncontrolled hypertension, congestive heart failure, arrhythmia, passing out, stroke. I studied them all. One more story to wake you all up if you're a little bit bored. I had a patient who came with a stroke, young woman in her 40s, and at that time I was not so much stimulated to do sleep studies in every single patient. So I did a transseptal echo. A transthoracic echo will show you all the chambers, but typical site of blood clot is in the left atrial appendage. left atrial appendage is not so well viewed without doing the transcatheter vagal echo. So I did the TEE, she had a small thrombus, I anticoagulated her, let her go home. I continued to follow her up. She had hypertension. One time I did a stress test, and it was about a year or two after, and she had uncontrolled hypertension. Then she mentioned to me symptoms of sleepiness, fatigue, and tiredness. I did a sleep study, it was abnormal. And then I put on CPAP, and then I realized how the dots connected. That may well be, she came to see me at the time with a stroke. Maybe she was still in sinusitis at that time, but she could have developed transient paroxysmal atrial fibrillation, leading up to a blood clot, causing the stroke. By the time we saw her, we saw the thrombus, but we didn't see the atrial fibrillation. So, but we managed her, and now knowing that she has sleep apnea, it's possible that she may have gone into atrial fibrillation then, causing the blood clot, causing the stroke, and now came to my attention. So it's very important to understand, and now I changed my practice on management of strokes with CPAP. And you want to listen to one more story? Okay. So there is a patient of mine, obese. She had bariatric surgery. You know what's bariatric surgery? Weight loss surgery. Who would come to the emergency room? I'm sure you have many patients like that. Come to the emergency room every 3 months with atrial fibrillation. So I adjust her medications, see if she has electrolyte imbalance. And low magnesium is a very important electrolyte imbalance that occurs and is actually one of the components of rhythm disorders. And many times I would replace magnesium. In fact, in one of the trials of ISIS, magnesium was one of the agents to be given. I was in England at that time. It was before the era of primary coronary intervention. Now, as you know, patients with acute myocardial infarction, in countries with facilities, we try to take them to the cath lab as soon as they arrive. So we open the vessel as soon as possible, which could be arrhythmia, congestive heart failure, loss of muscle, and sudden death. In fact, with this intervention, we had reduced many of those consequences. I'm drifting a little bit, but I think it's important. It's probably at least maintaining your attention. So we have been able to make a difference in the post-myocardial infarction outcomes, but we have not been able to make a difference in early myocardial infarction-related mortality. Anybody can tell me why? What is the early cause of death in myocardial infarction? Arrhythmias, yes. So somebody who has never been seen by a physician, has all the risk factors, has the first ever myocardial infarction event, which complicates with arrhythmia. It's impossible to interfere or deal with that or make a difference without implementing aggressive education in the public. That's why you may hear in some setups that we recommend baby aspirin after a certain age in people with risk factors. In fact, more recently, this recommendation is being a little bit questioned because of the higher incidence of complications of bleeding. In fact, one other drug has more impact on cardiovascular disease. Who will tell me which drug group that is? Which has a major impact on cardiovascular disease events modification besides aspirin? It's the statins. So the lipid lowering has a more important impact. So somebody who does not have hypertension, diabetes mellitus, does not have family history of coronary artery disease, doesn't smoke, and he's 50, he comes to you, should I start taking a baby aspirin? He's active, doesn't have any symptoms. So it's a very difficult question for me to answer. But typically, if they do not have any of the risk factors and their cholesterol is a little high, I'll get their cholesterol profile, I could get their A1C, I could do a treadmill test. I don't see any evidence. Then I would say, and if they have a little bit high cholesterol, I'll be relieved to recommend statin more than aspirin. So that's an important thing to remember, that early education could possibly impact primary prevention of heart disease that cannot be interfered with post myocardial infarction intervention. So the other story I was going to tell you was this lady who was obese, would come into my clinic, to the emergency room every 3 months or so with arrhythmia. And after several episodes of hospitalization, I said, why don't we test you for sleep disorders? I sent her to a sleep lab. At that time, home-based testing was not available. And the sleep lab called me next day that this patient went into atrial fibrillation in the night and she has severe sleep apnea. So again, that was a moment of reality. Light went on. I put her on CPAP treatment, and after that, her admissions to the emergency room markedly reduced. Instead of every few months, it would be more than a year or so later. So that was another important finding, that sleep apnea and atrial fibrillation are connected. So after a few years ago, home-based testing for sleep apnea became available, and I will talk briefly how we test. It's very intuitive to think about what would you test in sleep apnea. So if we describe the lack of ventilation, maybe if we check the ventilation with the belt, we put a sensor on the belt. If with the normal breathing, belt expands 3-4 centimeters, and if it doesn't expand at all, maybe it's just apnea. Similarly, we have an oximetry sensor, and if the oxygen declines, that's another important sensor. Then we have a sensor that's sensing snoring. Then we have a sensor which is airflow. We can add more sensors. We can have electromyography sensor. The list is long. EKG, ocular muscle, other myography, EEG, all those could be added. But for the purposes of cardiology, I do 100 testing. I've created hundreds of maybe for the common cases of that. So I would do oximetry sensor, a test extension sensor, airflow sensor, and snoring sensor. And that data is collected over time, which is in download, and then we introduce the process that data, take a look at it, and see when those actions is a consistent diagnostic, if that's the evaluation of strategy. So then we calculate that if it's a same event in ideal hours, when they were concurrent, lack of oxygen, there was airflow movement restriction, there was lack of resistance. When we call that apnea or hypopnea. So that's what the testing is. So suspicion, critical suspicion people in the first thing is global. So those people who are currently, they're sick all day, they're tired, they see, every morning headache, wake up with a headache, doctor is under control, and you see their treatment, after they open their mouth, into the office, the clearance has several types. One, you can see everything in the back, and the third type is not treatment. You just have to defend your wall. So the narrow the pharyngeal airway, the high percent. Then one highly prevalent subset of autism, high sick workers in public. So these people are using patterns, either on the wall or by the foot. So these people are very high prevalent. In fact, every single nurse working the night in the team, the different because in the ER, the people walk out after the he's getting the second one. And when you get out, the majority is recommended to another thing, if you suspect it, you can suspect happening. What are the chances that you will find the test to be positive? If you suspect it, more than 90% of the time, you suspect, given the dynamics of the population that we live, if somebody, I would not make this recommendation, but if I met somebody in the desert, there's nothing else to do, and he asked me all these symptoms, and I had no testing modality available, but I felt that his life was in danger, then I would ask him, okay, buy a CPAP machine and use it. Reason for that is, I didn't talk about what are the cardiovascular implications of CPAP. I made the association But why do I worry about sleep apnea as a cardiologist? Why? I would like you to kindly help me in answering that question. Anybody? Why would I worry as a cardiologist? Why do I worry about sleep apnea?
There's predisposal and precipitous cardiovascular disease.
Exactly. So these people have a very high incidence of stroke, very high incidence of myocardial infarction, very high incidence of uncontrolled hypertension, high incidence of arrhythmia, high incidence of congestive heart failure. No one asked me so far that there is two kinds of sleep apnea, obstructive and central. What's the difference and which is more prevalent? Actually, it's obstructive. It's obstructive, and that's also, it was a news to me, for me as well. I was also surprised that it's in the obstructive sleep apnea, by definition, the sleep center or the diaphragm mover is working. You have ventilatory drive, there is the stimulus coming to the diaphragm to work to cause a negative suction, to create that negative pressure in the trachea. But it's that nerve that I talked about, the tracheopharyngeal nerve, is not firing enough. So the pharynx is not trying to stay open at night in particular, which is causing that air movement is not happening either completely or partially. The diaphragm is trying to contract. So that would make very intuitive sense how to treat, that you augment this effort of the diaphragm by pushing little air with the continuous positive airway pressure. CPAP, positive airway pressure. So if the diaphragm is mounting a pressure of -8 centimeters of water, or 10 centimeters of water, but your throat is imposing a 10 centimeter pressure burden, so you have no movement. So that means that you would add, based on the severity of obstruction, you would add additional pressure to the air. And most machines are not automatic, which means they have a range. We set the range from 7 or 8 to 16 or 18. So based on the trigger of the breath, inspiration by the patient, based on the resistance, machines automatically feeds more pressure to get the air down into the lungs. That's the auto pattern. Most machines are auto pattern. So the testing we talked about, treatment we alluded to, CPAP is the number one treatment. A simple treatment, tennis ball. How? Anybody? How a tennis ball helps with sleep apnea? You serve it in your sleepwear, in a box. So you, like I mentioned, mechanism of sleep apnea is, once we sleep, if we lay flat, tongue falls back, muscles relax at night, and rapid eye movement also causes. So we need to relax our muscles to chill. That's how we recover. Sleep is crucially important to repair. One thing I forgot to mention, heart muscle. There's data. Heart muscle metabolism, very sophisticated, synchronized. 3 ways for the heart muscle to metabolize. The heart muscle is going to burn calories when we're active. It's going to store metabolites when we're resting. And it's going to heal the damaged organelles only in sleep. Now imagine if the heart muscle does not have the ability to heal its damaged organelles, mitochondria, cytochrome, all that activity is happening. So don't surprise why people who don't sleep will have a heart muscle disease. In fact, I have another story to share. I had a patient who came to me with ejection fraction 20-25%, and coronary is normal. I did the angiography, and normal coronary arteries, no arrhythmia. So it was not atrial fibrillation. And we do know that atrial fibrillation or arrhythmia can also cause a cardiomyopathy. It's called tachycardia-induced cardiomyopathy. Cardiomyopathy, cardio heart, myo muscle, pathology, pathology. So cardiomyopathy is a vast diagnosis. It's your clinicians who think about what causes it. Is it anemia in women? Is it hypertension? Is it thyroid disease? Is it excessive caffeine? Is it myocardial infarction? Is it some virus? Is it infiltrated? So, and sometimes people in cardiomyopathy will come in, we find multiple subsets available who are each contributing to heart muscle damage. And it's very common to find people who come in advanced, and you'll find many of the people come in heart failure, a large heart, and you don't have any coronary artery disease. Once you start opening the layers, you'll find multiple layers. So one layer could be hypertension, you treat that. One layer could be bad diet. One layer could be they have diabetes management. One layer could be they have arrhythmia. They're using so much caffeine, they're tachycardic all the time. To lower the heart rate. That's why beta blockers are the crucially number one agent in heart failure management. So 4 or 5 agents in heart failure management: beta blockers, diuretics, of course, right? ACE inhibitors, digoxin low dose. That's a crucially important agent. So all these are combination. Exactly. So you can keep on peeling off the layers by treating their sleep apnea is another layer, which I have incorporated in my practice. And so you see multiple things combining together in concert, causing heart muscle damage. And you're not expected to know everything at the beginning, but keep your eyes open and be vigilant as you go, and keep on making anemia in particular, in women in particular. Peri-pregnancy, anemia is extremely common and frequently ignored as a cause of heart muscle disease or symptoms. So women, perinatal, with heart failure issues, uncontrolled blood pressure, many times they have anemia, and that may be a major factor. So the heart muscle metabolism, it's in sync in a very sophisticated, synchronized energy production, then the metabolite storage, and repair and regeneration. If you remember these 3 things, that heart muscle has a sophisticated, synchronized mechanism of metabolism, which is also entrained with the clock. It's a biological clock. So if you are not allowing your heart to sync with the Earth's rotation, you are causing that person's heart to be at risk of damage. So 3 lessons from this talk so far is crucially important to know. Number 1, the mechanism is pharyngeal muscle disease. Number 2, it's an inflammatory disease. So these people have a high incidence of vasoconstriction, oxygen damage, procoagulants, uncontrolled diabetes, blah blah blah. Okay? Inflammatory cytokines are highly activated. Third important message is heart metabolism and the mention of the biological clocks and the Nobel Prize that went to someone who got the gene that only works at night. So if you remember these 3 things, I think I would have done my job. And briefly on treatment now, if the pathophysiology of that hypoglossal nerve is important, so there is the newest treatment for sleep apnea it's a special pacemaker. And that pacemaker is actually implanted with a tunneled electrode to the hypoglossal nerve, and you basically activate when you go to sleep at night. You activate, it's called Inspire, and it's not for every patient. It's people who have failed CPAP treatment, where the disease is such that they cannot tolerate no matter what. They're claustrophobic, or disease is such that it's severe. And I've still not talked about the implications of, actually I did talk about the cardiovascular implications. So that treatment is helpful, that we activate with a remote at the time we go to sleep, and it's timed in such a way that it works at that time when the inspiratory time, certain phase, where it will fire the genioglossus muscle, that part of the hypoglossal nerve, which supplies the genioglossus, which is going to open up the pharynx. The effectivity 50-60%, even after firing that muscle, the complications, infection, muscle fatigue, etc. That's just for you to know, more so to understand the mechanism than to expect this to be a treatment that we need to offer. So the number 1 treatment would be putting them to sleep. Like I said, the tennis ball treatment, I got drifted again in the interest of all students and doctors to try to give you as much information as I could. That sewing a tennis ball in the shirt, it will prevent them from sleeping on their back. So they will try to keep on turning side. Anytime they keep on their back, the ball is going to hurt them, they'll take a turn. And so they will be on the side, they won't have the tongue falling back as much, so they will not be as much at risk of. But generally speaking, educating your patients on good sleep habits, understanding light is as important for our health as much light, as much darkness is as important for our health, if not more, as much light is. And avoiding energy drinks and caffeine. And simplifying and trying to bring their biological clock or circadian rhythm in sync with the Earth's rotation. So I will stop here and I will take any questions, please. Thank you for being such an excellent audience.
So, thank you very much for this excellent talk. In fact, it's very enlightening. And I love the stuff that I learned in law about this very common phenomenon which is happening in our day-to-day life. I just wanted to ask one thing. Islamic teaching tells us to rise early and sleep early.
Sure.
It's in accordance with the circadian rhythm that you mentioned.
Sure.
So what you preach this thing that we should, discontinue the habits of waking up late and eating late and all that.
Sure.
And we should, all as Muslims, as we've been taught by our Holy Prophet, we should, switch back to those Islamic teachings.
Sure. Why not? It's crucially important to do that, particularly in a country where majority people are Muslim. And so I think wisdom and advice coming from any source of religion belongs to all humanity. And so, and knowing that, people who follow these customs are thinking of, so I think we are 100% certain. I think it's
And for all the youngsters who have not gone to the USA and Europe, they were adopting the same life. During the working days, गौरव जी आपको रात को 6 बजे 8 बजे को कंटिन्यू नहीं होता. Working days and the high not gone. Only on the weekends they used to have the waking hour for day to late night. But the rest of the day they used to sleep earlier and wake up earlier. Another point is that as has been said that you go to the physiology of the sleep apnea, there is a cascade of events, sympathetic system activation leading to the peripheral vascular resistance, increasing peripheral vascular resistance, then release of the cytokine, and inflammatory markers release,
rightly so.
and pro-coagulate.
Right.
So, I'm thinking that is there any role of anti-inflammatory drugs in there?
I do not know. Because these are all speculations. These are associations more than cause and effect. Excellent question you asked. And I was trying to read more this visit to see if there is more information available. I'm trying to get precise etiology. Why is that neuropathy? Is it diabetes causing it? And is it just an association? Or is it causal association? Does diabetes cause neuropathy? Is it a lifestyle? Is it the light? Is it some other disorder which is common denominator to both? We do not know. So there is a lot that you probably learn. Probably the sleep disorders are tip of the iceberg. And I was reading that the light itself, the spectrum we're talking about, the tiniest spectrum. What about the other spectrum of light waves, ultraviolet, infrared? And with the advent of technology and Wi-Fi, we do not know what are the implications of all these waves in our life spectrum, on plants and birds and animals and bugs, and how this whole interplay ultimately it's ecology, and we do know that how things are happening. So it's a more fascinating area. There's a lot of work is being done, but there's a lot more that is there. So I spent several years trying to see if there's a cause and effect. And I was trying to see is sleep apnea cause of heart disease? Is heart disease cause of sleep apnea? Probably in central sleep apnea, we didn't talk about much about central sleep apnea. We know that people who have changes of breathing, who have heart failure, their sensor does not fire
in those people, we know there's a very high incidence of sudden death. We talked about that. Then in people who have death at night, we know that there's a very high incidence of sleep apnea. We do know that the ACC, or bradycardia, is an important mechanism. So exactly what causes with this maybe lack of oxygen is an important driver. Should lead up to all the inflammatory cascade, cytokines, pro-glycan, oxygen damage, vasoconstriction, and the adrenal may well be. But then is driven from lack of oxygen, and when it is a mechanical problem. So rather, anti-inflammatory agents alone can have some impact, but that would be intuitively, instead of leaving it to reduce it to decay, we try to respond to it. So it may have some residual, like coronary disease, some anti-inflammatory agents somehow, but probably we need to go several steps back and try to impact the causes which are driving those factors than to just block these factors.
Another question is, another patient, Hypopian patient and obesity patient very hard to do this last surgery. Already on facing into diabetes, every time when you come with the process under dyspnea, the question is whether it is due to sleep apnea or it's due to lower dosage of the diabetes. Should we optimize the diabetes to we should go for the CPAP in such case, because you frequently come across
Right.
advanced heart failure, obese, heart failure, and coming with frequently coming the history of EMD.
Excellent question. I think you have the most important, relevant patient in the question pertaining to management. Probably the answer to that would be based on what kind of patient you're dealing with. If that patient is going to be receptive to your advice, if this patient is receptive to everything, I will do everything. And in fact, in my practice too, the people who say, I'm not going to do it, I'd rather die than to have beer with the mask. They're very strong, staunch. My own brother-in-law and my nephew, severe sleep apnea. In fact, my nephew lost his brother from sleep apnea because of this. And I brought a machine for him, I tested it. I did 2 pilot studies. And I said, I'm not here. I'm not going to. So, if you have a patient, and the answer to your question is, how strong a bond you make with that patient to accept your treatment. As a cardiologist, when I see these people with acute MI, I open their vessel, I scare them the very first day. I'm going to test you. You have sleep apnea, and that's the cause of your heart disease, and I'm going to test you. So with that interaction, I'm privileged in some ways, unfairly to you, that they listen to my advice, and compliance rate of testing and follow-up and compliance with CPAP treatment is very good, because I continue to scare them. If you do not treat your sleep apnea, you have a higher chance to have a sudden death, higher chance of uncontrolled hypertension. I show them some graphs in my office, some pictures. 70-80% incidence of stroke, incidence of uncontrolled hypertension, incidence of arrhythmia, then I also tell them it's called erectile dysfunction. You have mood disorders. So you have a better quality of life. And believe it or not, it's a learning curve for them to start using it. And some patients, this is the best night I've had to sleep. Others take few months, a stuttering course. But eventually they become believers. But there are people who are all the way in between. So coming to your question, I will do all that the patient can receive and accept, including aggressive medications. We know them all. Diuretic, naltrexone, whatever it is. And then look for some other causes. And then if they're willing to have a sleep study, do it. And then go on further. Oral appliances is another treatment, which basically tries, it's a dentist makes the appliance like a spacer or a denture-like device, which tries to lift the jaw forward, creating some space in the back of the throat, so reducing the tongue effective. It can make a 10-20% impact, maybe in minor sleep disorders, but comes at the price of causing so much distortion and disorganization in the mouth cavity, etc.
So probably I will not go into that area. Instead of that, I will recommend a tennis ball or some healthy education and scare them that if you don't, it will lead up to complications.
I don't think sleep apnea and PMD are entirely different things.
That's not true, but there is high prevalence.
Yes.
High prevalence of sleep disorders in those, and how they're related etiologically, I don't know.
Doctor sir, one question.
Yes, please.
You are saying that you are dealing with also arrhythmias. You are saying you are dealing with arrhythmia.
He has had everything done. Short of angiography,
Yes sir.
वो कराइए तो वो भी नहीं कराइए।
Yes.
इसका प्रॉब्लम ये है कि इसको दिन में किसी भी टाइम 2, 4, 10, 20 आ जाती है। And he is so apprehensive, so alarmed, so concerned कि ये मेरे क्लिनिक में हफ्ते में 2 दफा आता है, इसके पास जाता है हफ्ते में 4 दफा, अस्पताल में जाता है। इसको मैंने 10 दफा समझाया कि तुम्हारी पीवीसी की वजह से तुम्हें कुछ भी नहीं होता। अब आपकी बात करें।
Okay.
Doctor sir, I suffer from PVC for years. 18% PVC burden.
Okay.
Second question is skin burden.
Okay.
You must be for me.
No cardiac issue except PVC.
Okay.
My angiography also now.
Okay.
But I am unable to tolerate PVC.
Okay.
I feel dizziness,
Sure,
weakness. If I want to walk upstairs to achieve it, I feel too much tiredness.
You do.
I'm unable to
Okay.
upward walk.
So thank you so much for that information. So you have exercise-induced PVC.
No, they go away after exercise.
So if you on the, if I put you on the treadmill, if you walk or climb the stairs,
Normal.
so you don't have. So that's the good news, number one.
Exactly.
The good news is that if you had dangerous kind of PVC, then you would not be able to do those activities. That's the number one screen. So with this question, you're already in a very low risk population, but not to disrespect or deny or ignore your symptoms. I have a lot of respect for your symptoms. Sure. So in situation like this, there's some people who have a PVC in a certain area which is cumbersome. Probably you need to see an electrophysiologist. Occasionally those PVCs which are so much annoying require either antiarrhythmic or some ablation procedure based on my field is not electrophysiology. So probably if you came to my clinic, I would do a sleep study and I would do a treadmill test and I would then see if you had any restrictions in your lifestyle, such as caffeine use, tea, coffee, energy drinks, if you had any stressors, to try to bring your life as much in sync and balance with nature as possible, and relieve all those harmful areas of concern that could create these. So that's what I would do.
So actually the problem is that he is electric myocardial is not able to take the
Okay.
in fact, we did not say candidate for using that for the is not high. Actually, it's around 70, 80.
Okay.
And we use even 10 mg or 2.5 milligram.
Sure. So I don't see any abnormality in your interval. Your QRS is normal, your PR interval is normal. So I don't
There is no
suspect.
wrong.
Right. So
इसको
there's no
मैंने
wrong.
कहा डॉक्टर साहब ये कहा कि
Yeah. I think some by Germany, some place.
2-3 हफ्ते के लिए इम्यूनोड्रोम ले लो maybe that focus is suppressed
Right.
and then you maintain it 100 milligram OD for some time and that will be your
It's a toxic agent. So
Yes, उससे heart rate drop हो जाता है.
Right.
Actually, I wanted to give him some antidepressant.
Okay. That's a
But he is never convinced. He has seen many electrophysiologists, AFSC and in shop and so on. But nobody is not convinced to have this basic procedure in this case. The positive thing is that these PVCs are not easily diagnosed.
I don't see any harmful kind of
But symptoms.
reassurance. Reassurance is the crucial.
He is immune to reassurance.
Also, one thing is that I'm too asymptomatic when I'm suffering from PVCs.
Sure.
dizziness, vomiting, sweating.
I agree with Dr. Sam's recommendation.
Apart from thinking about the traditional effects of MI, diabetes, so now I have learned that I have also looked into another risk factor that is the secondary cause of diabetes like and myocardial infarction that is
Yes, it is important too. And in fact, there diabetes is not so, we don't have any randomized studies yet to say that the treatment is going to cause reduced incidence, but we have some suggestions. The strongest data is for hypertension. Like we know there's some studies, there's some conflicting data. Some studies show, oh, we treated these people, the blood pressure improved, others show they didn't improve. So we have conflicting data, but in my observation, I have seen improvement. And some other studies show a trend towards improvement in all cardiovascular events, including MI, including heart failure, including arrhythmia, including chest pain, and including hypertension, and of course, insulin resistance is crucially important. Insulin resistance in sleep apnea patients is another important factor.
Sir,
Yes.
sir, does sleep
In people with psychiatric disorders. So any psychomotor depressive agents are going to cause sleep apnea abnormalities. So psychiatric clinics, very high prevalence. Narcotic, pain medication usage clinics, very high prevalence. Because if you remember the seesaw, anything that adversely affects the seesaw, either stimulants or depressants, is going to affect sleep physiology and cause a high prevalence of these general disorders. Good question. Yes, please. I'm so happy your students looks like they listen to me and they're all asking me questions. Is this a question at the back? Yes,
सर
please.
स्लीप एपनिया का क्या रिलेशनशिप है एजिंग के ऊपर और ओबेसिटी के ऊपर और दूसरा मेरा क्वेश्चन ये है कि जिन लोगों की नाइट शिफ्ट वर्क्स होते हैं उनके लिए आपकी क्या सजेशन है कि वो इसके एडवर्स इफेक्ट्स को कैसे कोप अप करें
बहुत अच्छा क्वेश्चन है आपका एजिंग के ऊपर इट्स हायर प्रेवलेंट इन ओल्डर एज एंड इन फैक्ट वो लोग जो हैं वो दे नॉट पिकविकियन जो बहुत फैट भी नहीं है उनके अंदर इसका हाई इंसिडेंस है अब उसका मैकेनिज्म क्या है उनको फेरेंजियल मसल मायोपैथी क्यों हुई डोंट नो तो उसमें क्या उनकी लाइफस्टाइल में ऐसी चीज़ें थी कि किसी लोग को नाइट वर्कर्स से या उनमें डायबिटीज थी या कोई और टॉक्सिन से या कोई और रीजन न्यूरोपैथी का वी डू नॉट नो बट वी सी अ वेरी हाई इंसिडेंस ऑफ हाँ एक और बात भी है समटाइम्स उनके अंदर डेंचर्स कम हो जाते हैं छोटे हो जाते हैं तो उससे उनकी बाइट ज़्यादा स्ट्रॉन्ग हो जाती है which pushes the tongue back. It's an excellent question you asked. So it's a high incidence. Night shift workers may, that is a dilemma. It's a societal dilemma. So I think in those people, educating them could well be the best way to do it. Just emergencies में जिन लोगों ने काम करना है, you can stop police or health etc. But have a high prevalence, have a higher suspicion, index of suspicion. So try to implement them in other aspects to reduce the severity of the disease. They avoid caffeine, etc. What was the third part you asked me?
एजिंग
Aging का मैंने बता दिया कि उसमें
ओबेसिटी एजिंग
obesity of course. Obesity, the number one Pickwickian disorder.
Syndrome, obesity, Pickwickian syndrome.
Yeah. Obesity में it's a much higher incidence. The classic description of sleep apnea is obesity. Obesity hypoventilation syndrome. और जो चार्ल्स डिकन्स का जो मैंने कैरेक्टर आपको दिखाया that was this picture shows you Hypopian in people with psychiatric disorders. So any psychomotor depressive agents are going to cause sleep apnea abnormalities. So psychiatric clinics very high prevalence. Narcotic pain medication usage clinics very high prevalence. Because if you remember the seesaw, anything that adversely affects the seesaw, either stimulants or depressants, is going to affect sleep physiology and cause a high prevalence of these general disorders. Good question. Yes, please. I'm so happy your students looks like they listen to me and they're all asking me questions. Is this a question at the back? Yes,
सर
please.
स्लीप एपनिया का क्या रिलेशनशिप है एजिंग के ऊपर और ओबेसिटी के ऊपर और दूसरा मेरा क्वेश्चन ये है कि जिन लोगों की नाइट शिफ्ट वर्क्स होते हैं उनके लिए आपकी क्या सजेशन है कि वो इसके एडवर्स इफेक्ट्स को कैसे कोप अप करें
बहुत अच्छा क्वेश्चन है आपका एजिंग के ऊपर इट्स हायर प्रेवलेंट इन ओल्डर एज एंड इनफैक्ट वो लोग जो हैं वो दे आर नॉट पिकविकियन जो बहुत फैट भी नहीं है, उनके अंदर इसका हाई इंसिडेंस है। अब उसका मैकेनिज्म क्या है, उनको फेरेंजियल मसल मायोपैथी क्यों हुई, तो उसमें क्या उनकी लाइफस्टाइल में ऐसी चीज़ें थी कि किसी लोग को नाइट्रिक वर्कर्स से, या उनमें डायबिटीज थी, या कोई और टॉक्सिन से, या कोई और रीजन है न्यूरोपैथी का, वी डू नॉट नो, बट वी सी अ वेरी हाई इंसिडेंस ऑफ। हाँ, एक और बात भी है, समटाइम्स उनके अंदर डेंचर्स कम हो जाते हैं, छोटे हो जाते हैं, तो उससे उनकी बाइट ज़्यादा स्ट्रॉन्ग हो जाती है, which pushes the tongue back. It's an excellent question you asked. So it's a high incidence. Night shift workers may, that is a dilemma, it's a societal dilemma. So I think in those people, educating them could well be the best way to do. Just emergencies में जिन लोगों ने काम करना है, you can stop police or health, etc. But have a higher prevalence, have a higher suspicion, index of suspicion. So try to implement them in other aspects to reduce the severity of the disease. They avoid caffeine, etc. What was the third part you asked me?
Aging.
Aging का मैंने बता दिया कि उसमें
Obesity, aging.
obesity, of course. Obesity, the number one Pickwickian disorder.
Syndrome, obesity है ना, Pickwickian syndrome.
Yeah. Obesity में it's a much higher incidence. The classic description of sleep apnea is obesity. Obesity hypoventilation syndrome. और जो चार्ल्स डिकन्स का जो मैंने कैरेक्टर आपको दिखाया, that was this picture shows you
We'll add everything done. Short of angiography.
Yes, sir.
वो कराइए तो वो भी नहीं कराइए.
Yes.
इसका प्रॉब्लम ये है कि इसको दिन में किसी भी टाइम 2, 4, 10, 20 आ जाती है. And he is so apprehensive, so alarmed, so concerned कि ये मेरे क्लिनिक में हफ्ते में 2 दफा आता है, इसके पास जाता है हफ्ते में 4 दफा, अस्पताल में जाता है. इसको मैंने 10 दफा समझाया कि तुम्हारी पीवीसी ठीक हो जाती तो इसमें देखता. अब आपकी बात करें.
Okay. Also, I suffer from PVC for 18% PVC burden.
Okay.
Second question is 3%.
Okay.
This must be for me.
No cardiac issue except PVC. Okay.
My angiography also now.
Okay.
But I am unable to tolerate PVC.
Okay.
I feel dizziness.
Sure.
Weakness. If I want to walk upstairs for 3 minutes, I feel too much tiredness.
You do.
I'm unable to
Okay.
upward walk.
So thank you so much for that information. So you have exercise-induced PVC.
No. They go away after exercise.
So if I put you on the treadmill, if you walk or climb the stairs,
That is normal.
so you don't have. So that's the good news for number one.
Exactly.
The good news is that if you had dangerous kind of PVC, then you would not be able to do those activities. That's the number one screen. So with this question, you're already in a very low risk population, but not to disrespect or deny or ignore your symptoms. I have a lot of respect for your symptoms. Sure. So in situation like this, there's some people who have a PVC in a certain area which is cumbersome. Probably you need to see an electrophysiologist. Occasionally those PVCs which are so much annoying require either antiarrhythmic or an ablation procedure based on my field is not electrophysiology. So probably if you came to my clinic, I would do a sleep study and I would do a treadmill test and I would then see if you had any restrictions in your lifestyle, such as caffeine use, tea, coffee, energy drinks, if you had any stressors, to try to bring your life as much in sync and balance with nature as possible, and relieve all those harmful areas of concern that could create these. So that's what I would do.
So actually the problem is that he is ready Myocardial is not able to take the person.
Okay.
In fact, he is not candidate for using the for using the is not high. Actually, it's around 78.
Okay.
If you use even 10 mg or 2.5 milligram.
Sure. So I don't see any abnormality in your interval. Your QRS is normal, your PR interval is normal. So I don't
There's no
suspect.
wrong.
Right.
इसको
There's no
मैंने
wrong.
ये कहा डॉक्टर साहब, ये कहा कि
Yeah.
I did some bi-diabetes, some
2-3 हफ्ते के लिए immunodrome ले लो, maybe that focus is suppressed, and then you maintain it 100 milligram OD for some time, and that will, be your.
It's a toxic agent, so.
Yes, उससे heart rate drop हो जाता है.
Right.
Actually, I wanted to give him some antidepressant.
Okay. That's a.
But he is never convinced. He has seen many electrophysiologists in AFSC and in SHARP and so on. But nobody is convinced to have this invasive procedure in this case. The positive thing is that these PDCs are not easily diagnosed.
I don't see any harmful kind of.
But symptoms.
Reassurance is crucial.
He is immune to reassurance.
Also, one thing is that I'm too asymptomatic when I'm suffering from PVCs.
Sure.
Dizziness, vomiting, sweating.
I agree with Dr. Khan's recommendation.
Apart from thinking about the traditional research of MI, diabetes, so now I have learned that I have also looked into another research that is a secondary cause of diabetes like that, and my body is something that is legal.
Yes, it is important too. And in fact, diabetes is not so, we don't have any randomized studies yet to say that the treatment is going to cause reduced incidence, but we have some suggestions.